Good afternoon and welcome to Grand Rounds today. Please remember to fill out the attendance record at the back of the auditorium, and then also, if you could, please remember to fill out the program evaluations and give the CME committee any ideas that you might have in regards to future topics or future speakers. We're always on the lookout for those. Today I have the pleasure of introducing Mark Noon. Mr. Noon holds a bachelor degree in occupational education and a master's in human resource management. He is a retired major in the United States Air Force, and while in the military he received extensive additional training in several disciplines, particularly in laboratory technology and biotechnology. He was the recipient of multiple honors and awards, and he is currently a healthcare coach for the Studer Group, and he has kindly accepted our invitation to come up to Ames today to discuss with us improving clinical outcomes through patient experience. And please join me in welcoming Mr. Noon.
All right, thank you so much. Well, good morning. You guys can hear me okay? All right, excellent. When Tim was hooking all these wires up to me, I felt like I was going to get an EEG, an EKG, an EMG, all the different EE, whatever they are. And I feel there may be things running through my headset here. I'm not even sure what Tim's got hooked up back there, but this is kind of an unusual situation because I don't get I do a lot of instructing and coaching and teaching around the country, but I don't always look up at the audience in such a way. I might even get a kink in my neck by the time we're done. This is quite a steep incline. And I guess nobody really likes to sit up here in the front, do they? That's good, because when I speak, I get pretty excited about what I talk about. I'm always very enthusiastic, and I call this, you ever been to SeaWorld? I call this the splash zone. This is where I spit on people, so it's really pretty good that you guys are up top. So thanks so much for the opportunity to be here. I flew in last night to Des Moines. I live in Florida. I live in Destin, Florida. Anybody ever been to Destin, Florida? Excellent. Yeah, the whitest sand beaches in the world. Really a fantastic place to be. Dr. Hallberg and I were just talking about Destin, and I actually live in a town right near Destin called Niceville, Florida. So does it get any better? It does get better. So listen to this. I live on a street called Sparkleberry Cove in Niceville, Florida. Right, that's that. I'll show you my driver's license if you don't believe me. It's honest to goodness truth. So what a privilege to be here at Mary Greeley. Vicki Choate is your coach, one of your coaches, and Vicki invited me to come and spend some time with you guys. I really want to talk about, what's the clinical outcome of the patient experience? How does that affect what happens with our patients? We all of you know what HCAPs are, and now we have CGCAPs, and we're going to talk a little bit about those in just a few minutes. And the patient experience scores, and really, hopefully, a lot of you are very familiar with those scores and what they kind of represent for you guys as a hospital. But I want to talk specifically today as we move through this about how we can affect that and how the clinical outcomes are changed. For instance, my dad is a diabetic. He's 75 years old, lives up in the Upper Peninsula of Michigan where I grew up originally. And, sometimes I think if it wasn't for me, I don't know that he would take as good care of himself with his diabetes as he should. And you guys know, you have patients like that. If we don't spend some time really explaining things to them to help them understand the outcomes of what they do for themselves to take good care of themselves, sometimes we don't get really great results. And what that means when I talk about patient experiences, the more time we spend with a patient or the more better communication we have with a patient, typically the better they're going to take care of themselves, which means we have better clinical outcomes, right? We have better A1C results. My dad and I talked on Sunday, and his latest A1C result was in the 8 range. Well, obviously 8 is not very good for a hemoglobin A1C. So he knows that, and he's well aware of that. He's been cheating lately. But he realizes also that he's got to spend some more time preparing his day so that he doesn't get his sugar out of balance. So it's things like that I think are very, very important. If you're familiar with the Studer Group, which I'm going to trust that a lot of you are, but I always go over this in anywhere that I go because I want to make sure you understand our mission is to make Mary Greeley the very best place for your staff to work. But also, and I highlighted up on the top, for your physicians to practice medicine. And I know we have a great mix of all kinds of clinical and administrative staff today. But if you'll allow me just a little bit, I'm going to really focus specifically to our physicians, our providers in this, but all of you will see how relevant it is. Making the practice of medicine so much better. I was on a webinar this morning, so I started out my day this morning at 7 o'clock with a call with one of my hospitals in Omaha area. And we were talking with physicians about the practice of medicine. How do we make the practice of medicine better so we don't have burnout, we don't have such excessive burnout with our physicians? How do we make the processes that we do in medicine better, more effective, so that we don't get so stressed out? You guys know, how many days, what is it, the 4th day of November now? So 35 days ago, we had a big stressor hit the medical community. What was that? ICD-10, right? And the estimate was the average physician, average provider is going to spend 4 minutes more on the computer per patient because of ICD-10. So if you have 20 patients a day, that's an extra hour and 20 minutes of time. So how do we make that process better for practicing medicine? That's why it's so important that's part of our vision. And then the ultimate of that is what? Terrific patient care. Because if you guys as staff members are really excited about what you do, and our physicians have great processes in the practice of medicine, and they're excited about what they do, and I say physicians, really providers, then isn't the ultimate outcome great patient care? And great patient experience, but also great clinical outcomes? Absolutely. When I talk about engagement, and that's probably one of my favorite topics to talk about with organizations around the country, is engagement. So anybody up here engaged to be married right now? Anybody? Anybody willing to admit that? No? You guys remember what it was like when you were engaged? Those of you that are married now, you remember those days? You remember engagement was one of those times where you had butterflies in your stomach when you thought about that other person, or the end of the day was coming and you knew you were going to meet them for dinner for somewhere, and you had kind of that feeling in your stomach. I don't expect that all of you are engaged in the organization to such that at 6 o'clock this morning when you woke up and got ready for work, that you had butterflies in your stomach because you were so excited to be here. I realize that. But what does engagement mean? And engagement simply is this. It means partly embedded in being in gear, or better yet, unavailable for anybody else. And so we're engaged in an organization if we're truly committed to the organization, and we're committed to the values of the organization, which yours are the word pride, correct? Then I think we are going to have the best clinical outcomes for our patients. And so engaged means I'm unavailable for anybody else. That's why women wear engagement rings, right? Ladies, do we wear and we like the big things on our, we want people to know that, right? You watch women with engagement rings. I don't know why guys don't wear engagement rings. I'm not quite sure. Maybe they're still available for somebody else. I'm not sure exactly why. What I love about your values of this organization is, I see values of organizations all the time. Sometimes as many as 9 different values, sometimes as many as, as few as 4 or 5. People-oriented. That's a good thing to be in healthcare, right? People-oriented. Respectful. But I love the third one is innovative. And I think in healthcare, in order to be the most efficient with what we've been given and the circumstances that are in healthcare, that whether good or bad, however you want to look at that, we need to be innovative. We need to figure out the best ways to be innovative, to have innovation, to create the best possible experience for our staff, which translates to our patients. You're dedicated and you're effective. I like that one. Honestly, I've never seen the word effective as one of the values of an organization and all the ones that I've coached in. So I like that, effective. Because to be effective, you've got to be innovative as well. Student group, our expertise, we build skills. A lot of you have probably been through some of the skills labs, especially if you're in a nursing area, clinical areas. We get results. Hey, I looked at your HCAP's results this last week. How many nurses do we have in here? Who's a nurse? Nurse communication. You guys, did you see your third quarter results? What were they? You remember? 95th percentile on nurse communication. That is phenomenal. I think you guys deserve a hand. Go ahead and give them a hand. And that, from what I saw, the last 4 quarters, you guys have been ranging in the 30s and 40s, and all of a sudden this last quarter, you jumped to 95%. So what happened in this quarter? Somebody tell me. And I'm picking on you 3 because you all raised your hand, but I know there's other nurses in here. What happened this last quarter that all of a sudden you got nurse communication in 95th percentile? Do you guys know? What's that? Rounding. Maybe rounding. Okay. Now, here's what else I saw. How many physicians do we have? Doctors, providers. Yeah. Have you guys seen your scores, the latest HCAPS results for this quarter? I think I saw 88th percentile. 88th percentile. So give our physicians and our providers a round of applause. And again, from what I saw, quarterly for the last 4 quarters was in the 40s range. Dr. Hallberg, maybe you know exactly 40s range, and all of a sudden this last quarter we jumped up to 88th percentile. Something had to have changed in the last quarter that all of you have done to improve that patient experience. Why is that so important, that patient experience, and those particular scores? We're going to talk about that in just a little bit. Organizations coached by the Studer Group tend to outperform other organizations around the country. That's just me bragging about what we do. But you guys are an actual example of that because you've seen this incredible gain in results in the last quarter. All the HCAPS results, you can see the ones that typically we tend to improve on even more rapidly than others. Nurse communication, doctor communication are the ones we have the hardest time moving organizations in, and yet you guys moved, I don't know, 50 percentile points in a quarter. That's phenomenal. That doesn't happen very often. So I very much want you to pat yourselves on the back and talk about that and recognize each other for such a great job. Here's one I wanted to show you too is the emergency. Anybody work in the emergency department? Anybody? No? They're out there saving lives, right? Okay, you guys, oh, you do. You're the lone emergency department person here? Okay, so you work in the emergency. Gotcha. Okay, very good. So we know that when emergency department results improve, patient experience, we know that it translates to great inpatient experience as well, right? If you had a bad experience in the inpatient side, you guys, do you work inpatient? No? Who works inpatient nursing? Nobody? Where are those people? They're doing the job. You guys are kicking back, eating lunch. Those guys are doing the work. I see how it goes. All right. We know that when they have a great experience in the emergency department, it translates to a great experience in our floors as well. Just some statistics for you. If you've ever had any of Studer Group, you've heard any of our speakers, you've heard any of our coaches, had any interaction with any of us at all, you always see this. You guys have seen, anybody ever seen the flywheel before? Hopefully you've seen that quite a few times. We focus on the purpose, worthwhile work, and making a difference. Don't we have a purpose in what we do every day? I hope that maybe some of those butterflies you have in your stomach in the morning when you get excited about coming to work because you're engaged in the organization are because you have a sense of purpose and you know that you do worthwhile work and you know that you make a difference every single day in what you do. But here's what I want to talk about. We're going to talk about some prescriptive things. Now, anybody ever taken a prescription for something? Yeah? Anybody ever given out a prescription for something? Quite a few of you, right? Why do we do that? Somebody tell me why we take a prescription. What does it do for us? Makes you better. How does it do that? What's the process that we do in a prescription? What makes it make us better? I don't mean the scientific stuff. What's that? Okay, we treat the symptoms, or we treat what the root cause is. We consistently take our prescription, right? If we consistently do it, we tend to get better. Like my dad, who wasn't doing so well on his diabetes, he gets an 8 point something on his hemoglobin A1C. He wasn't being very prescriptive, was he? Or when we go to the emergency department, let's say I have a sore throat, which I do sometimes because I speak a lot during the week, and I go to the emergency department or my doctor's office or wherever, and I say, my throat's sore. What do? They do a test for strep throat, let's say. I get a prescription because they say, yeah, you got strep throat, I'm going to give you a prescription. Prescription is typically what? Antibiotic. How many days do I take that antibiotic? How many days is it prescribed for? 7, 10, right? Okay, all right. You guys can talk. That's all right. I know you got a mouthful of food, but go ahead, talk. It's okay if you spit on the person in front of you. That's all right. So, yeah, 7 to 10 days. How many times a day? 2 to 4 times a day, depending on the medication, right? How many days do I actually take that prescription? All of them. Yeah, you got some really compliant patients here in Ames, Iowa, don't you? How many do I really take it? 3, 4, till I feel better. And then what do I do with that prescription? No, I discarded it properly like every pharmacist would tell me to do, right? Sure. No, I put it in the medicine cabinet because medicine cabinet is not for your current medications, it's for the ones you're keeping for that time when you get sick, right? So we take this prescription until we feel better, and then all of a sudden, 3 or 4 or 5 months later, we get sick again, sore throat. Mark says to himself, I don't have to go to the doctor. I got this prescription, so I just start taking the antibiotic again, and then I feel better, right? So the same thing when we talk about, anybody ever heard the term ADET? Ever heard that one? ADET, A-I-D-E-T, that's something we coach really strongly in organizations. So we start doing ADET, or we start rounding on our patients, we start rounding, hourly rounding, and we do that as a prescriptive, and then we get great results like 95th percentile. And we go, whew, 95th percentile, we're feeling pretty good. What do we do then? We stop rounding, or we stop doing ADET, or we get a little lax on it. We don't take our prescription like we're supposed to, and what happens? Our results start to go down. Our results start to go down, what happens? We go to the prescription, we go to the medicine cabinet, we pull out the ADET, we pull out the rounding, we pull out these prescriptive things that we do, and then we start feeling better again. But if we take a medication on a regular basis, Lipitor, thyroid medicines, whatever that is, and we do it as prescribed, we tend to have great success in the long run, right? Which keeps that flywheel continually turning. So we talk about some of these things today that we do, we will do, or if we haven't done them before, we will do, to improve the patient experience, which improves the clinical outcomes, then that's our prescriptives. What does that do for us as an organization? How about increased physician engagement? How about decreased left without being seen, decreased no-shows? Now, those are some monetary things, but aren't they important for clinical outcomes too? That if we have good, effective processes in the emergency department, that there's a good flow there, that patients don't leave who truly need to be seen, isn't that a better clinical outcome? Absolutely. If patients leave the hospital with good discharge instructions and we call them the next day and we find out that they've got their follow-up appointment, they've picked up their medications, they're doing everything that we've told them to do, isn't that good clinical outcomes? Yeah, absolutely. How about reduced turnover in the organization? Doesn't it get frustrating sometimes when you have departments that turnover is really high and we're constantly training new people? Do we have a lack in quality with our patient outcomes if we have a increased turnover? Absolutely. Sure we do. Because we're constantly, continually training new people. And not that these aren't qualified people, committed people, but the level of expertise is not such. We want to improve those kind of things. We call this our evidence-based leadership model, just like evidence-based medicine. How many of you prescribe a medicine that isn't evidence-based? No, nobody raises their hand. Oh, you do up there. No, okay, you do. she just gives it out. No, just kidding. Yeah, so we have this reason why we use evidence-based medicine when we practice it. We know that things are, we just don't give out whatever because we heard about it, read about it on the internet, whatever. Some patient came in and said, hey, I heard this, can you prescribe this? And we say, yeah, it's not really FDA approved, but we'll go ahead and find it for you. We don't do those kind of things. We go through a particular evidence-based process. We diagnose, we treat, we follow up. The aligned behaviors within that evidence-based leadership model, if you look at the middle part, is that must-haves, right? So why do you think we call these the must-haves? Not a trick question. Why do you think? Because we must have them, right? That's what we consider the must-haves, because we must have them. We consider these the elements of every organization that brings the very best patient experience and also the very best clinical outcomes. The one specifically we're going to talk about today is keywords at key times, which is what AIDIT is related to. Ladies, you mentioned rounding, that's on there. Thank you notes is really about recognition. Employee selection is really about how we hire people, the types of people that we hire, the process that we go through to hire people. And then the pre- and post-visit phone calls. Are you guys doing post-visit phone calls in every area in the hospital? Yeah? Anybody ever got a post-visit phone call from an IT department? Oh, yeah, wouldn't that be cool? So come fix your computer today, and tomorrow they call you and say, hey, I just want to check and make sure your computer's still working. Wouldn't that be cool, huh? I just put your IT folks on the spot now. Right, Tim? You hear that back there, Tim? That's IT, you're doing post-visit phone calls. All right. Let's talk about HCAPS a little bit. Let's talk about what the questions are. Because I want you, if you don't understand what these questions are, we need to know that. I'm going to guess that the majority of you do. But you know what? My daughter, both my daughters play college volleyball at Mercer University in Macon, Georgia. My youngest daughter just started last year. Her roommate is from Oregon. Her mom is a hospitalist in Oregon. I met her a year ago. The mom's been a hospitalist for 3 years. She's been a physician for probably about 8 years. Not a real long time. She started a little bit later in life. So she's a hospitalist. Okay, I said that like 3 times, right? Last year when I was talking to her, I asked her about HCAPS. She had no idea what HCAPS were. Now, how do you work in an inpatient setting as a hospitalist and not know what HCAPS are? But you know what I'm finding is that a lot of our providers do not know. And a lot of our nursing staff know what these are, but they don't always know what all the questions are either. And then we have this, anybody working in medical practice, not in the hospital, but in the McFarland Clinic or somewhere else? Yeah, several of you, right? Now we have CGCAPS, which is the clinical group CAPS. And guess what? ED CAPS, that's coming along the line too. We're going to have surgery, ambulatory surgery CAPS. We have home health CAPS. All these things are coming if you haven't already seen them. But these are the ones I want to specifically talk about. Now, I focus this again specifically to our providers today versus the entire staff. There's a lot more questions than just doctor communication and nurse communication. There's 12 now questions on the HCAPS. And CGCAPS is, escapes me how many questions there actually are. I say broad questions. There's 12 broad questions on the HCAPS, but there's actually 3 to 4 subset questions in there. These are some of those. So, providers especially, how often did you treat your patients with courtesy and respect? Somebody tell me, how often do you do that? Do you do it always? I hope you do. I'm thinking, you probably think you do. right? And this quarter, you guys hit 88th percentile on that part of that question on doctor communication. So always is 100% though, correct? Am I right? Always is 100%. But yet we only have 88%. 88% is really good, let me tell you. But it's not always, is it? So how do we know always that we're being courteous and respectful? Nurses, same thing. Similar questions on the nurse part of HCAPs. How do we know, this is feedback time. You guys can talk without your mouth full. How do we know we're being courteous and respectful? Ask. How do we do that? What do we say? How do we know what courteous and respectful is to our patients? I don't know. Tell me. What do you think? That's a hard question, isn't it? Because it's different for every single patient. Absolutely different for everyone. How often did the doctor listen carefully? How do we know that we're listening carefully? What's that? Eye contact. What else? Sitting. What else? Not in a rushed manner. How else? Follow-up questions. Yeah, so let me hear you correctly. This is what you said, right? I have a CEO I work with at a particular hospital. He and I have the hardest time communicating. He and I have a harder time communicating than my wife and I have communicating. We've been married for 27 years. Because when I communicate with him, and it's not his fault, not my fault, but it's this combination, we have to have the same question 3 times in a row before I get it. He'll say something to me, and I'll say, so what you're saying is this. He'll go, no, Mark, this is what I mean. I'll say, okay, I'm listening. He goes, and then I'll repeat it back. So what you're saying is this. No, Mark, literally it's about an average of 3 times. I think it probably is me. My wife would tell you it's me. But anybody in a similar situation? But it's my responsibility. It's not his responsibility necessarily that I don't get it. My job as the coach is to listen and to understand. Next one. How often did doctors explain things in a way you can understand? How do we do that? How do you guys, and I don't mean just doctors, but all of you as clinical staff, how do we explain things to patients so they can understand it? Give them questions, open-ended type of questions, right? Have them repeat back, teach back. What else? Common language. Yeah. Now I'm a lab guy. That's kind of my background. So I if I tell you guys I need a CBC and a TFT and a LH, FSH, that's no big deal, right? You guys understand that for the most part. Our patients don't understand. And that's just my typical little acronyms. Then I have my military, because I was 20 years in the Air Force, so I have all my military acronyms too. And you start spewing all those things out. Oh my gosh. So you confuse the patient. We used to confuse medical patients because of our military acronyms and our medical acronyms. They would just be totally spaced out. How do we explain things in a way they can understand? Asking open-ended questions. Here's a tip for you. Here's a tip. So if we go to Dr. Hallberg, I'll use an example. So if I go to Dr. Hallberg and he's my patient, and I say, so Dr. Hallberg, I've given you a lot of information today. I'm sure you have a few questions. What would those questions be? Is that a pretty good answer? You think I'm going to get some good feedback? Probably. Because I've said to him, you know what? I gave you a lot of stuff. Tell me. I'm inviting him to ask questions. Now, I know some of you are probably a little leery about that, because as soon as you do that, the whole window of questions open up, or the whole list comes out, and then you're thinking, I don't have time for this. But if we allow that environment, I remember this, my mom passed away in 2010, and my dad afterward was telling me about a lot of her doctor's experiences, because I was actually deployed in the Middle East at the time, and so I wasn't around for some of this doctor experience that my mom was having, and my mom was the type of person who went into the physician's office, and he or she, whichever physician she was seeing, would say things, and my mom would just do the typical head nod thing, right? She was 65 years old, do the head nod thing. That's kind of her mindset of, doctor says it, I'm going to do it. I don't understand it, but I'm going to do it. Come out, my dad would say, what did he or she say? And she'd say, I don't know. And he'd get so frustrated, like, why don't you ask questions? And why? Because my mom, who did not have a high school education, felt very inferior to people who were very well educated or professionals, and so she felt inferior and felt like she couldn't ask questions. So I always look at that and I say, how do we invite our patients who may feel exactly the same way to ask those questions? Because if we don't, now my mom had AML. There's no cure for that. There was nothing that was going to necessarily prolong my mom's life. So it wasn't like these questions that she would have had would have prolonged her life, but maybe it could have made it a little bit better. And that's the kind of things that I look at. How do we explain things in a way? So let me go back to my example now. Dr. Hallberg, so I say, I've given you a lot of information, and I'm sure you have lots of questions. What can I explain better? Now I've taken that whole responsibility back on myself as the provider of care to say, I'm sure there's things you don't understand because I get it. I've been through medical school, and there's still things I don't understand. I mean, that's, what can I explain to you that will help you? Because if we explain it better, what's going to happen? We have better clinical outcomes. Look at the CGCAPS questions. Now we take provider communication and we expand it from 3 questions to 6 questions. Did I explain things that were easy to understand? So not that you understand it, but they were easy to understand. Now we've taken it even another level. Did we listen carefully? That one's already there. Did I give you easy to understand instructions? How many of you have ever discharged a patient with a packet of discharge information and said, here you go, you're discharged, we're going to sign you out, and away they go, and here's this packet of stuff. How often do you think they read that? They never read that stuff. We don't even read that stuff. I go get a prescription at the military base where I live, and I get a 2-page information about the contraindications and all the different things about the medications, the side effects, and all those things. Nobody ever explains it to me, but I just get the list, and I'm supposed to read this and understand it. How do we have easy to understand information? How much did the provider, and this is, it says provider, but this is, guess what, for all of you. Anybody who has contact with a patient. How do they know, that we know the important information about their medical records? Because we go in and what do? The triage person asks them a whole bunch of questions. Well, first of all, they get to the front desk and they register and they get asked a bunch of questions. And then they go to triage and a person asks them the same questions over and over again. And then when the provider comes in, what happens? You spend the first 5 minutes asking the same questions, right? How do we communicate behind the scenes, make processes so much more efficient? Because you guys are both physicians. I think you both raised your hand, right? No, you are, yes. So if you go in and you're using ICD-10, it's now going to take you 4 minutes longer per patient. And it's already taking you 5 minutes to get a medical history. That's 9 minutes of my 15-minute appointment, of which I needed 13 of those 15 minutes to do my assessment. Now all of a sudden my appointments are 25 minutes. But if I know that information ahead of time, somehow, some way, and the process is better, the outcome's going to be better for our patient. Did I spend enough time with you? Do we ever spend enough time? Do our patients ever think we spend enough time? Tell me, do we? Do they? I don't know. You can probably tell I'm a little ADD. So when I get in, I want to be in and out quick. I don't need a lot of time. Just tell me what I need to know, push me around, give me my medication, whatever. Let me go. Some people need that time. Do we have processes in place that allow us to spend more time with patients we need to and get some of them out a little bit quicker? Last one. Show respect for what you had to say. How do we do that? You guys, how do you personally show respect for what the patient has to say? Anybody? Uh-huh. Excellent. Yeah. Right. They listened to what you said. They went and checked it and said, hey, that was a good choice. Did you know that some of the questions that are now being asked of our patients are related to how much input they had into their own care? In other words, you said to them, typically, here's what you need to do. This is going to make you better. And they went, okay, let's go do it. Now the questions are, did they actually spend some time with you talking about some of the choices that you have? So you might say, this is an option, this is an option, this is an option. What do you think is the best thing for you as the patient? Right? Again, my dad, I always use my dad as an example. Now, he's not always the best example because he's one of those people that sits around my little hometown up in Upper Michigan. He's been in for 35 years and knows everybody. And you know how some of these folks sit around and talk about the local hospital? Because they'll tell you everything that ever went bad, and it could have happened in 1962, but it's still relevant today, even though things have changed. So my dad actually went to the emergency room recently for some back issues, spent 4 hours there. His estimation, 4 hours. My guess, probably 2. My dad always doubles everything. He's a good storyteller. But the physician who came in, the question was asked about getting x-rays on the back. And the physician basically let my dad and the person, his friend that was there helping him get to the hospital, let them both know that they were not medical providers. X-rays do nothing. Why would you even think that we're going to do X-rays? Again, my dad's impression of what happened. Now, that doesn't matter whether it fully happened that way or not, but that's my dad's perception of how the care was. Had the person taken time and said, you know, we used to do X-rays for this, but here's why we don't, and here's what's the best course of treatment for you, or the best diagnostic treatment. Those are the things that would have mattered a little bit to my father. And again, I don't take my dad's word at anything when it comes to what happens in the world of healthcare. We have a local hospital in that area. It's called Bay Area Medical Center. That's the name of it. The locals call it barium medical hospital. And I don't mean barium like enema. I mean like barium 6 feet under, barium. Okay, that's why. So that's, and again, it goes back to, you know, however many years ago that's the impression of what goes on there. How do we account for all these things? And what does it matter? What does it matter? Here's what it matters, is if my dad had a little more explanation, and I'm not saying it's his fault or the provider's fault, maybe his A1C wouldn't be at 8.5. Maybe there would have been some more opportunities for him to control that. Maybe there would have been some other opportunities for him to control. What he really liked was after he did hurt his back several months ago, had to be transported in an ambulance to the hospital, he really liked the fact that the home therapist, the physical therapists that were coming to his home, really spent a lot of time telling him all the ways he can help himself. Because that's my dad. He's a truck driver, been a truck driver for 55 years. He's still driving truck at 75 years old. He still wants to load his own trucks. He wants to do all those kind of things, right? How can he not hurt himself and still do the things he wants to do? It's important that we show respect for what's being said, take into account what it is, and then communicate that back to our patients. Over the next decade, and you guys are probably already seeing this in a lot of ways, there's a lot of reimbursement, there's a lot of financial ties to all the things that have to do with patient experience. If we don't get better patient experience, which we know has better clinical outcomes, because we reduce readmissions, we reduce people returning to the ER for things that they don't need to be there for, we're going to lose a lot of money in our hospitals. What happens if we lose money in our hospitals? Anybody? Now, I was just telling Dr. Hallberg, when I was in the military, if we lost money, we didn't care because we just asked Congress for more money and they give us more money, right? We didn't care about those kind of things. What happens in your hospital if you don't make money? Or if you lose money continually? Eventually, you don't have a hospital. Or you don't have services in the hospital. You're not able to properly take care of your patients. So are clinical outcomes important? Yes. Is patient experience important? Yes. These are all tied together. Vision without execution is hallucination. You ever heard that one? How many of you have great vision on January 1st or 2nd? Anybody know what that vision is? Yeah. I'm going to get in shape. I'm going to lose weight. I'm going to do that, right? All that great vision. I work out at my local gym, the Air Force Base where I live. And every January 1st, there's only about 10 of us that are regularly there at my 4:30 time slot in the morning. I like the early morning time. There's about 10 of us that are regularly there every day or every week when I'm home. January 2nd, all the resolutioneers show up, those people with great vision, and they take all our machines and they use all of our equipment. Of course, you know, we're the 10 people that own this gym in that time. It's our time slot. But we always know by about February 1st, all those people are going to be gone. It's going to be back to the 10 of us. We can handle that because we know a lot of them don't have a great execution. We have great vision about what we want this place to be, what we want our medical practice to be, what we want to be as providers of care. Without the execution of that, we're just hallucinating. We've got to combine quality, we've got to combine safety, and we've got to combine the patient experience together in order to get there. It's not one of those things, not any one of those things is going to make it. We can have great patient experience and horrible quality. Could we have that? There are some elements there. Could we have great patient experience and lack of safety? Certainly we could. If we have a combination of all three of these things together, there is no stopping any organization from truly succeeding and being the best place for care. The biggest obstacle to achieving the highest performance is an urgency for change, is a needed urgency for change. So we have to have an urgency, we also have to create an urgency. What are some of the barriers that might prevent you as providers, as givers of clinical care? What would be some of the barriers that would stop you from communicating really well with our patient, or listening really well, or taking into account their preferences? What are some of the barriers that might happen? Time. That's always the first one, right? How many patients do we see a day? 30. And your day starts at what time? 8 and gets done at what time? Supposed to get done at what time? 4:30, right? How do you see 30 patients in that time? Is it possible? Yes, with the right efficiencies and systems, certainly. What happens to your day? What time do you typically get done? Yeah, later. That's a good answer. Good answer. Sure, time is a barrier. Is it an internal problem or is it an external problem? Is it because of the processes we have within our system or our clinic or our area? Or are there external things that cause our time to be a barrier? What other kind of barriers might there be? Here's a big barrier. How about consistency? Have you ever, I talk about this a lot of times in organizations, is you ever gone, emergency room especially. Emergency room, you got several different rooms. All the rooms are laid out exactly the same. Same cabinet, same bed, same computer area. But you go to the drawer, third drawer down on the left, and in one place it's this particular supply item, and you go to the next room and it's the fourth drawer down. Those are the kind of inefficiencies sometimes that are internal that we can fix and we can correct. We've got to have alignment. We've got to have a readiness for change. We've got to have consistency throughout the organization, consistency in how we treat our patients. Again, remember I said that if the emergency department patient experience is not very good, it's really hard to make it up on the other end. If they go to surgery, and then they go to ICU, and then they go to inpatient, and then they go to rehab, and then they go home. All of those areas are almost having to make up for what might or might not have happened in the emergency department. On the other side, they had a great experience in the emergency department, and then they get to the inpatient floor, and they're delayed for 2 hours to get there because of whatever process, system, they don't know. And then all of a sudden, the person that gets them isn't creating the same good experience. What happens? We have poor patient experience. We have people who don't trust us with the things that we say, the things we're supposed to do. Consistency. So are the barriers external or are they internal? We actually use a chart, and I don't have it here because it's pretty extensive. And you look at the internal barriers, you look at the external barriers, and you decide, are they truly barriers or are they excuses? You ever had somebody who talked about how busy they were all the time, but you never really saw them do anything? Have you seen people like that? Oh, it's busy, right? But you never really see them accomplish anything. I had one person that worked with me years ago, my first lab I was ever in the military. And I used to give this person a hard time because it wasn't that I was rude. Well, maybe I was a little bit rude, but and I was kind of young and immature, and I would say things like, well, you don't really do anything. And she came to work one day with this list of all her responsibilities. It took her 20 minutes to go through the list with me. In that 20 minutes, she probably could have done half the things on the list, but she had to tell me how busy she was all the time. So sometimes we have these excuses, and sometimes we have barriers. Here's my classic example. So I live in Destin, Florida. And how many of you know there's sharks in the water? Okay. Well, recently, this guy was caught about 100 yards offshore in Destin, Florida. It's a mako shark. Now, to my knowledge, and I did some research, I've done research, there's never been a human attack by a mako shark in the Gulf Coast area. So it's pretty ominous looking. Looks like a great white shark. This one's 12 feet long. This is only 100 yards offshore, which means it's very shallow water. But is this, so I saw this was last spring. I haven't been back in the water since I saw this. Now tell me, is that an excuse or is that a barrier? Do people still go in the water in Destin, Florida? So if people still go in the water, am I using that as a barrier for Mark Noon not to go in the water, or am I using it as an excuse? I think it's a pretty darn good excuse myself. But so when we think about all the things that we have to do to improve the patient experience, are there barriers? There may be. Are they internal, external, or are they truly just excuses to say, I can't because of this? What are the outcomes of this? And this, we're wrapping up. We got about 10 minutes for question and answer as soon as I finish this last little bit. What are the benefits? For physicians, here's the benefit. Better clinical quality. Better performance as an organization financially. How about greater peace of mind? Wouldn't you love it if you could sleep all night long and not get called in the middle of the night because something didn't go right because there's efficient systems? Wouldn't that give you a greater peace of mind? Wouldn't it be a greater peace of mind that you let a patient go home, discharge them, with the full confidence that they're going to do everything you expect that they're going to do because their discharge instructions were good, you communicated really well the importance of things, and that you know they're not going to get readmitted in the next several days or not going to have to come back to the emergency room because they didn't follow up? How about more satisfied patients? And really it's beyond satisfied patients. I mean, you ever had a meal and you were satisfied? It was okay. I was satisfied. I ate breakfast this morning at my hotel. Typically, Hilton Garden Inn's a pretty good breakfast. I was satisfied this morning. It filled the void, but it wasn't a great experience. Ever had a great experience at a restaurant? The wait staff was awesome. The cook came out and introduced themselves to you. Everything was hot. Everything was perfect. Everything tasted exactly the way it was supposed to. That's an experience. And what do you do when you have an experience like that? You tell your friends about it. It's not just satisfied. It's about experience. How about decreased readmissions, reduced no-shows? Those of you that work in the clinic, wouldn't it be nice to have a reduced no-show? All of a sudden you expect to get a patient, nobody shows up. That's not very fun. How about for our staff, or for our patients, sorry? A better place to receive care. Is there any place else in Ames, Iowa that people could go for health care? Is this the only hospital? Okay, what's the closest hospital? How far? Sorry? 9 miles away is a hospital somebody could go to. If they thought they could get better care there, would a patient go there? Even though you guys are bigger? Supposed to be better? Yeah, they could, certainly. I work with a lot of rural hospitals. Rural hospitals, sometimes it's all you got, 65 miles from nowhere. But people that live within 30 miles of the hospital, who could go 30 miles the other direction to another hospital, they'll certainly do it if they think they're going to receive better care. Better manage pain, better understanding of their medications, the side effects, the contraindications. Just recently, my wife takes a thyroid medicine. Recently, she was asking me some questions about it because she wasn't sure it was quite working like it's supposed to. And I don't know why I never looked this up before, but I decided, why don't I look up the contraindications and different inhibitors to the thyroid medication, and found out magnesium is a huge inhibitor to her thyroid medicine. My wife takes a magnesium pill every single day. Well, obviously her thyroid medicine, she was starting to feel a little down. Her thyroid medicine maybe wasn't working well, so we decided not to take the magnesium anymore. See how that goes. Knowing that kind of stuff. Now, not everybody's going to look that up in the internet, and I know you guys don't like those internet doctors out there who just look things up and come in and tell you what's wrong with them. But people who understand what's going on in their health care. Increased market share, fewer readmissions. Questions for me? We're right at the end of our time. I appreciate your willingness. Yes, sir. Oh, we got a microphone. Gotcha.
One of the things I hear frequently, and it actually happens in my department as ambulatory care, not inpatient, but outpatient care. Many departments have physicians where there are too many patients, the demand is great, we have to double book, we sometimes triple book, we're running behind. We have interruptions during the day from other providers wanting immediate attention to the other providers' problems, so my department is running behind and constantly interrupted. And one of the solutions is to restrict access. And so how do you feel about some departments that we've been recruiting for 10 years, we can't get enough providers?
Yeah.
I'm a neurologist. So one of the ways to reduce double bookings, triple bookings, interruptions, patient delays is to actually restrict the number of patients that we see in our department. So how do you feel with regard to access versus patient experience? Because sometimes you can't do them both. And so what's your feeling about access versus patient experience?
Yeah, that's a great question, and not an uncommon question by any means. A couple things. When I think about, first of all, is communication. How do we communicate to our patients? One, the importance of their appointment, so we don't have no-shows. If we can reduce no-shows, I think we can manage our slots better, so we don't have to. Sometimes I think we double book because we think this is going to be a no-show or we have too many no-shows. If we can reduce no-shows, I think we can manage that process a little bit better. Second is communication with our patient about the availability of our providers, and are they willing to go see somebody else if needed, or are there other ways to get access to care. So I realize limited number of neurologists. So how many can take care of how many patients there are? Are there other things that other providers can assist you with? And I don't know the answer to that we can communicate so patients feel comfortable going to see somebody else. They've only seen you for 20 years. You're the same doctor they've seen. They trust you, everything. How is that communicated to our patients say if, when we do bring in another provider, that they're willing to go see that other provider and build up that practice. So again, it's about managing up those other areas to improve that care. Processes that we, again, talking about if we add in ICD-10, that's not going away. That's a barrier. Is it a barrier? Absolutely. Is there an external barrier? Absolutely. But are there internal processes that we can do to make things better? Scribes sometimes in organizations to allow providers more time so that we have, again, scribes aren't the full answer. Some places it doesn't work. I've seen it not work, even though they thought productivity would go up. So there's processes like that. I always look at the practice of medicine. What are the delays? Now we're looking at internal barriers. Are there internal barriers that prevent the access? So we have to see, like the provider who just left, seeing 30 patients a day. If you have to see 30 and you're booking 40 to try to get that 30 because of no-shows, that may be a problem. Or is it 30 and all of a sudden we can't even see 30 in that time slot because we have things that are slowing us down? Does that make sense? Other things that you guys can think of that might help this gentleman solve that process with access? Things that you're doing in your clinics? If you remember our evidence-based leadership model, there's 3 parts to it. It's aligned behavior, aligned goals, aligned behavior, and aligned processes. In organizations, we know that if the goal is this and everybody's in alignment to that goal, we're successful. Then we add in the behaviors like ADIT and rounding in the process. Then we can get to where we have consistency in behavior, then we have consistency in processes. Yes, sir. Further.
Yeah, obviously, I've been thinking about this a lot.
Yeah.
I asked John Noseworthy, who's actually a neurologist, and he's now gone up to be CEO of Mayo Clinic. And I asked him about 8 years ago at a conference what they did in neurology at Mayo Clinic. And I said, we send people to Mayo Clinic, but they refuse to see them. They say they're too busy and they can't put them on the waiting list. They just can't see them. And so I asked him, how you seem to turn away about half the people that are referred to Mayo Clinic. And he said, oh, no, we actually refuse to see 2/3 of the people that are referred to neurology at Mayo Clinic. Now, we don't even have psychiatry at McFarland Clinic any longer because we couldn't keep psychiatrists here. Yeah. So again, it's a matter of how many providers can you recruit, and it is really difficult.
It is, absolutely, and that's nationwide. I told you I deal with a lot of rural hospitals. Now imagine rural hospitals, 65, 100 miles from nothing, or out in the nowhere, and trying to get physicians, especially of certain specialties, to go to those areas is very difficult. I think the other part of it is, how well are we communicating? How well are we instructing our patients in taking care of themselves so that maybe we can reduce the number of appointments that we have to fulfill down the road as well? If we have to have an appointment in order to take care of a patient that really we could have done in another manner because of good instruction or other outpatient opportunities, I think we can also alleviate some of that access. It's about process, and that's where we have to have consistency throughout the organization to get the process. And one of the reasons I asked for a show of hands of anybody else that had an idea is a lot of times you get in meetings like this or times together, there are people that have a solution to what you're looking for. We just don't share it because they work in another building or they work in another part of the hospital, so we don't see them, we don't communicate, we don't ask those kind of questions. Good question, thank you. Other questions about anything we talked about today? Nothing? All right, Dr. Albert, anything else? All right, thanks so much, folks.